非常谢谢岳一章秘书长这个邀请到这个重症的大师。Good morning, Professor Philip Dellinger. Thank you for taking your valuable time to prepare the lecture and speak to us online. Thank you for donating your honorarium to Taiwan Society of Critical Care Medicine, and we will use it to revise and promote the Taiwan consensus of critical care of COVID-19 patients. I will shortly introduce to the audience all the members of the Taiwan Society of Critical Care Medicine and the Taiwan Society of Emergency and Critical Care Medicine, and also Taiwan Association of Chest Medicine and Critical Care Medicine. I will shortly introduce in Mandarin and then get back to you. Please wait for a while. 那大家都知道，这个 Dellinger 教授是国际级的这个败血症的大师，那也是大家所熟知的 Surviving Sepsis Campaign 2004、2008还有2012连续3年的第一作者，那是国际著名的败血症的大师。他目前在美国纽约 New York City 旁边的 New Jersey Cooper Medical School of Rowan University 担任教授和重症医师。那其实他的过去的 training 是非常的令人钦佩。他曾经参加过越战，然后回美国以后才念这个医学系。所以在学术上 ，Critical Care Medicine 的副主编，也是所有美国 Surviving Sepsis Campaign 的理事。那发表的论文著作超过200多篇。那另外，他目前还是第一线的重症医师，还是参与带领团队来照顾重症病人。在 COVID-19 的重症病人，他也有很多的经验，所以今天他要分享他的临床经验，还有医学实证。所以我们就热烈欢迎 Professor Dellinger. Professor Dellinger, please start.
Thank you very much, Professor Wang, for that introduction, and I'd like to thank the Taiwanese societies that are the sponsors, the societies, critical care medicine, emergency and critical care medicine, pulmonary and critical care medicine, anesthesiologist, and the Healthcare Quality Association. It is a pleasure to be here with friends and colleagues. I wish I was there live. I have been to Taiwan on multiple occasions, have enjoyed the time there, and appreciate the high quality of critical care that's delivered in Taiwan. It's I guess I'll bid you good morning, although it's 8:10 in the evening where I am here in New Jersey. So we'll get started. So we're just coming down from the peak of our second surge here at Cooper, right outside of Philadelphia. We still have a very
Professor
busy
Dellinger.
COVID
Sorry.
ICU, but it is the volume of critically ill patients is. So we're just coming out of our second surge. I've got both of my vaccinations since the middle of January. Everyone in my hospital that wants a vaccination, which thank goodness is the great majority, have the vaccination. But it's interesting to look back on the last year of COVID. I have no potential conflicts of interest for this talk. What I'm going to do over the next 25 minutes or so is talk about coping with COVID-19 critical care information during uncertain times, talk about where we are with steroids in COVID-19 ARDS, and discuss COVID-19 as an indication in its own right for full anticoagulation. Let's begin with coping with COVID-19 critical care information during uncertain times. I think all of us can remember in the beginning the conflicting literature and expert opinion, difference of opinion was clearly very prominent in the literature, urging us to do it this way or that way. The introduction of the postulating two different phenotypes of COVID-19 ARDS that met ARDS by the Berlin criteria, an L phenotype that didn't have a lot of infiltrates, compliant lung, low VQ. In fact, very low VQ was postulated that might explain the severe hypoxemia in the absence of a lot of infiltrates, and because there was not a lot of lung infiltrates, not a lot of capability to recruit, versus the H phenotype, which was more traditional ARDS, the way most of us look at it in the ICU, with high lung weights, dense consolidation, very non-compliant lungs, high shunt, and high lung recruitability. While some were postulating the L and H phenotypes, others were offering caution about premature phenotyping, recognizing that we've always dealt with a lot of different causes of ARDS because ARDS is a syndrome, not a specific disease entity, and that we have made success in treating all ARDS with certain basic principles. So the concept that an L phenotype might lend itself to using higher tidal volumes or not recruiting or other ways of treating it different by this group, caution was urged. And similarly with the question of to intubate or not to intubate, that is the question. Some people felt that you should avoid intubation at all costs because the thought was that once the COVID-19 patient was put on a ventilator, the chances of mortality were very, very high. Others were concerned about self-inflicted lung injury from high works of breathing and mechanical power, and felt that early intubation was indicated in order to control mechanical power. It was also a time, looking back over the last year and continuing until February of 2021, where we changed to some degree the way we did business with publications and social media. This is a protest sign. What do we want? Evidence-based medicine, evidence-based science. When do we want it? After peer review. So some of the rules of peer review were violated during the COVID pandemic, and to this day, I'll show you an example at the end of my talk. But we were seeing more and more early preprints of clinical trials. We were seeing even press releases of preliminary results of clinical trials, and these preprints and press releases were not infrequently presented to the public and presented to physicians before data lock. Having run a lot of international clinical trials, you always wait until after you clean the data and after what's called data lock, after you go through all the data and make sure that it's all accurate before you do the analysis and are willing to release the results, and even peer review. We were seeing preprint publications as they were submitted to journals. And this, I think, was very confusing to the practicing clinician as to when should they change the way they treat the COVID-19 critically ill patient. Should they wait until the publication is peer-reviewed, or could they rely on this very early release of information? And social media had a field day with COVID, including critical care. All of the tweets about personal interpretations of some of the earlier released clinical trials that had not been peer-reviewed, as well as a lot of difference of opinion about interpretation of clinical trials. So the clinician was often confused as to the decisions. Things like convalescent plasma, which I think now is something that's not recommended. Steroids we'll talk about. Hydroxychloroquine has gone by the wayside. Remdesivir is still here, but probably not for mechanically ventilated ICU patient. Tocilizumab remains controversial. I'm going to talk about full anticoagulation. Non-invasive ventilation and whether it may be associated with the patient self-inflicted lung injury. I think early on there were some concerns about using non-invasive ventilation. I think now non-invasive ventilation is a very accepted treatment modality that is and should be used and may avoid intubation. Awake proning, the word's not still in on it. How long to extend proning? Clearly, we are proning patients much longer than the traditional 14 hours and up to 24 hours in many occasions. So we're seeing more breakdown. We're seeing a lot more use of veno-veno ECMO and decisions of withdrawal of support in these patients that may have very prolonged ventilator stays and just aren't getting better and aren't getting worse. When I lectured at here with you virtually in September, I showed this slide. I just want to show it again because I think a nice solution for a hospital that's struggling with conflicting literature is to have regularly scheduled Zoom meetings for their faculty and treating clinicians to share personal experiences, discuss new literature, talk about difficult cases, and try to get consensus on approach to these patients. I know we found that very helpful in a lot of different areas. For example, we agreed, particularly while there was discussion about H and L phenotypes, that it would be best to set PEEP by driving pressure and not by ARDSNet PEEP tables. So where are we now in February of 2021? I think back in March, probably the majority of people felt like COVID-19 ARDS was going to be very different than the traditional etiologies of ARDS. And by December, the pendulum was swinging more back toward the midline of traditional ARDS. And in February of 2021, I think it's even closer. My feeling is that in the end, COVID-19 will be a syndrome variant of ARDS that will have some very distinctive characteristics, in particular as it relates to things like hypercoagulation. So the Surviving Sepsis Campaign published the COVID guidelines in March of 2020. And very recently, in fact, less than 3 weeks ago, published the first update of those guidelines, and allows me to use that update to discuss a couple of key treatment decision areas. So first, I want to talk about steroids for COVID-19 ARDS, because the update for the Surviving Sepsis Campaign COVID guidelines now has a significant recommendation in that area that was not there in the March 2020 guidelines. Let me take you back to pre-COVID. After 2 decades of back and forth on the use of steroids for septic shock and ARDS, we had our first high quality study published in March of 2020 on the use of dexamethasone in moderate to severe ARDS. There are no COVID-19 patients in this study. All the patients had a PaO2 FiO2 ratio of equal to or less than 200, a p-10, got dexamethasone 20 milligrams IV days 1 through 5, and 10 milligrams IV days 6 through 10. There were almost 300 patients in this study, and the results heavily favored the use of dexamethasone, both for mortality and ventilator-free days. So you would think that as we came into the COVID pandemic and we're seeing COVID ARDS, that the decision would be, yes, we should use steroids, we should use dexamethasone, and we should use this dosage. However, that wasn't the case for good reason, I think, and that is that there were essentially no viral ARDS patients in this DEX-ARDS study. So we still didn't know about viral ARDS and steroids. In fact, 2 studies from the H1N1 pandemic a little over a decade ago raised serious questions about the use of corticosteroids in H1N1 ARDS, where it was difficult to show evidence of a beneficial effect of corticosteroids in registries or cohort data, and even a suggestion of harm or higher mortality. And the concern was that steroids might hamper the body's capability to clear virus. And then we had the dexamethasone in COVID study published in the New England Journal of Medicine first in July, a randomized controlled trial showing a significant survival benefit of giving dexamethasone 6 milligrams PO or IV daily for up to 10 days. And the choice of this lower dose of dexamethasone clearly was looking for the sweet spot where you might choose a dose of dexamethasone that would ameliorate the inflammatory aspects of the viral effect in the lung without significantly altering the body's ability to clear virus. And then there was a meta-analysis published in September of 2020 that supported steroids in COVID ARDS. And now with the update to the COVID-19 SSC guidelines, there's a strong new recommendation that says for adults with severe or critical COVID-19, we recommend using a short course of systemic corticosteroids over not using corticosteroids. And for adults with severe or critical COVID-19, consider steroids, dexamethasone as the corticosteroid of choice. And if dexamethasone is not available, use a corticosteroid that's equivalent to 6 milligrams daily of dexamethasone for up to 10 days. So we're now using the dexamethasone 6 milligram daily dose on patients that have severe or critical COVID-19. And by the way, the data for the dexamethasone 6 milligrams daily for 10 days would be for any COVID patient that's requiring oxygen and any higher grade of respiratory support. If you look at the data for COVID patients that are not requiring oxygen, there's actually a better outcome at that stage of the disease with the placebo group. So probably should not give steroids to patients with COVID-19 that are not requiring oxygen. And in the last 8 minutes, I wanted to talk about COVID-19 as an indication for full anticoagulation, and that is that fully anticoagulating just because of the diagnosis of COVID-19 without any traditional indications for anticoagulation such as thromboembolic disease diagnosis. It's clear that we're seeing a lot more thromboembolic disease in patients with COVID-19. We seem to be seeing, the data supports greater than 30% higher incidence of thrombosis, thromboembolic disease in COVID as opposed to traditional ARDS. Here you can see a saddle embolus in this patient on a CT pulmonary angiogram. Here you can see a clot in the vena cava shown by ultrasound. We also have seen arterial thrombosis and pathological evidence of pulmonary thrombotic disease, microthrombosis, one of the postulated reasons why we may be seeing severe hypoxemia in patients that don't have a lot of infiltrative lung disease with very low ventilation perfusion driving the hypoxemia. So this has led to a lot of empiric anticoagulation of COVID-19. This decision tended to be made in the patients that were sicker, in the ICU patients, in the mechanically ventilated patients, in the mechanically ventilated patients that were getting worse, and in the severe COVID-19 patients, especially in the presence of high D-dimer. But is and was that the right thing to do? There was even cohort data published. I mean, this is not randomized clinical trial data. This is just looking at a collection of data from an area of the country. This, I think, was from New York, in which they just analyzed retrospective cohort data and concluded that outcome was better in patients with COVID-19 that received full treatment dose anticoagulation. Now, There was a lot of disclaimers on this data. It was observational, potential for unobserved confounding. Didn't know why the patient was put on anticoagulation. There could have been another acceptable traditional reason. Lack of metrics to classify severity of illness and indication bias. And there's a downside of full anticoagulation empirically in COVID because we know we see bleeding in this group, and we certainly seem to see it in patients that we've decided to anticoagulate. The recommendation from the 2021 COVID-19 guidelines was that there was no recommendation. And the update said that there is insufficient evidence to issue a recommendation. So this update to the COVID-19 guidelines came out, I think, January the 28th, saying there wasn't any data to allow a recommendation. And on that same day, the ATTACC Acti4A Remap CAP multiple platform released their interim analysis. Again, this is just a couple of weeks ago, 3 weeks ago. It's not peer reviewed, it's pre-publication, but the DSMB recommended to stop the clinical trial, stop enrolling patients in the clinical trial. And the reasons for that were that the interim conclusion in severe state in patients that were on ICU level organ support at baseline that were randomized to full dose anticoagulation when there was no other reason for full dose anticoagulation did not improve organ system free days to day 21, and raised the possibility that it was harmful in these patients with a trend in increasing mortality and a very impressive increase in major bleeding events and mortality. So I think the message is out now based on this trial. This is 3 different platforms. This is a very large trial. Would indicate that we should not be empirically anticoagulating our ICU patients that have no other reason to receive full dose anticoagulation. And it also had a recommendation for superiority in the group that were hospitalized and not on ICU organ support. Therapeutic dose was superior to just usual care venous thromboprophylaxis with regard to organ support free days in each D-dimer subgroup. So they looked at patients that did not have an elevated D-dimer, had a moderate elevation or a high elevation, and it held up that the full dose anticoagulation patients did better in this moderate state of hospitalized, not on ICU organ support, and a very low dose, a low rate of major bleeding. So for our ICU COVID patients that don't have another reason for full dose anticoagulation, there is data that demonstrates efficacy in improving outcome with thromboprophylaxis dose heparin, and that should clearly be used in all hospitalized COVID patients, including ICU patients, but the full dose anticoagulation, not for the ICU level care patients. So in summary, we continue, I think, to cope better and better with COVID-19 critical care information. I think it's beginning to solidify the decisions that we're making. I think there's now evidence of a clear signal of benefit of steroids in patients with COVID-19 that require oxygen and does include our critically ill ICU patients. And COVID-19 is an indication for full anticoagulation only in the more severe patients that would be going to the ICU. Not in those patients. So not in the ICU patients, only in the hospitalized non-ICU patients. Thank you very much.
Professor Dellinger's talk is open for discussion. So any question from the audience? Please give microphone to our audience.
So when you talk about the use of steroid, so you just mentioned the dexamethasone is better than other steroid. Can you explain the reason?
Why is dexamethasone is superior to other steroids in the management of critical care patients with COVID-19?
I think I understood the question. The only study that's been done in COVID-19 patients that was a randomized trial that has been published, there may be other studies to be published, used dexamethasone. And the reason dexamethasone was used was because of the 2020 published study, the VR study, that also used dexamethasone and showed benefit in ARDS, non-viral ARDS. So I think we don't have head-to-head comparison of dexamethasone versus other steroids such as salumedrol. And we may not get those studies. So the recommendation is, since the evidence-based medicine supports the use of steroids based on dexamethasone trials, it would make sense to use dexamethasone unless you don't have dexamethasone available, and then you would choose an alternative steroid, but choose a dose equivalent to the 6 milligrams of dexamethasone.
Thank you. Professor Dellinger, you do not mention the specific treatment for COVID-19. Could you make a brief comment on the lower or remdesivir or COVID-19?
Yeah, I mean, I think remdesivir is indicated for patients that are hospitalized with COVID-19, with the exception of those that are mechanically ventilated, where data would indicate that it is not of benefit, and you would have to deal with the drug interactions. I think, having said that, we have had some patients that have essentially come into the hospital with rapid declines, where the onset of symptoms was very recent, and they had a rapid decline, and such they were essentially came to the hospital and were admitted to the ICU. And we have made an exception in that group and given remdesivir.
Thank you. Any questions? Please.
Thank you for the nice talk. Thank you for the very informative lecture. You mentioned just quickly in a sentence about non-invasive ventilation. You suggest to use that in COVID critical care patients, and what do you think is the risk and usage of that point? Thank you.
Yeah, I mean, I think when we first started treating these critically ill COVID patients, we were concerned about viral transmission with a system that was not as closed as mechanical ventilation. The same thing as high frequency nasal cannula. We didn't know how good our PPE, our protective equipment would be. We now really feel comfortable with that aspect of using high frequency nasal cannula and non-invasive ventilation. The other concern with non-invasive ventilation would be allowing patients to generate high negative intrapleural pressure and tidal volumes that were higher than lung protection strategy for ARDS. For example, I've had situations where a patient was on non-invasive ventilation and you go in the room and you see that their tidal volume is 10 mLs per kg predicted body weight. And if that patient was mechanically ventilated, you'd have that down to 6. So you're weighing, are you getting patient self-inflicted lung injury because the patient's negative intrapleural pressure is generating these high tidal volumes. And, I several occasions, we've discussed at the bedside, this patient looks comfortable on non-invasive ventilation, but these tidal volumes are higher than what we would like. I mean, should we sedate the patient? Well, we don't like to do that on non-invasive. Should we intubate the patient just to decrease the tidal volume? That's a difficult decision too. In general, we have allowed those patients to run higher tidal volumes, particularly if they don't have dense infiltrated lung disease, based on the theory that maybe there is this L phenotype of more compliant lungs. But the one thing we don't do is we don't allow a patient to stay on high frequency nasal cannula or non-invasive ventilation if the observation of the patient at bedside is that they have a high work of breathing. So if they look like they're breathing hard, we'll intubate that patient.
And Professor Dellinger, I'm curious about the current status of COVID-19 in Lowen University Medical Center. Current status, how about it?
I'm sorry, I missed the question.
Yeah, I'm curious about the current status of COVID-19 burden on the Cooper Medical School of Medicine of the Lowen University in your hospital.
About the service itself?
Yes.
Yeah, so, at the height of the first surge, we had over 60 patients on the ICU service, and we had up to 40 that were on ventilators. The main ICU was filled with COVID patients. The CCU, coronary care unit, was filled with COVID patients, and we opened up a regular hospital ward. We had ventilators in the private rooms, which was scary. We haven't had to use the CCU or the hospital floors with this most recent surge. We did get a lot of help with the first surge. The critical care docs only had to take care of COVID patients. All of the non-COVID patients were taken care of by non-critical care anesthesiology, by the trauma critical care, by the hospitalist, and a lot of the physicians in training, the internal medicine residents and the surgery residents shifted over to help with the intermediate COVID unit. We certainly learned a lot about disaster preparedness. And I'm sure you've seen the articles that have been published about dealing with personnel resources and being able to staff during COVID. It's not been as bad this time, and hopefully it won't be as bad as it was then again.
Thank you, Professor Dellinger, and I hope you will stay safe and United States also overcome the COVID-19 pandemic. Thank you for your excellent talk.
It's indeed been a pleasure.
非常精彩的演讲哈，他的确美国现在还是都被 COVID-19 占满了哈，所以还是一样，其他科的医师还是要训练照顾其他的 COVID-19 的病人，跟我们 SARS 的时候大概有类似的一个 situation。好，那下一位我们就邀请潘英宇医师来介绍下一位讲者，潘护理师。